time for another student webinar. This is number 31. How exciting. We are going to talk about coding in pregnancy. And what I did was I highlighted a few things that we'll go over and just some basics that you need to know if you're going to start doing the OB or the pregnancy codes. Most of the time, I want you to know that this is going to cover both outpatient and inpatient. So I did several topics kind of on inpatient, just things that I want you to highlight, things you need to be aware of, and probably be a good idea to go ahead, have your notebook out so that you can make yourself notes and then add these notes to your ICD manual. So the first thing that you need to be aware of is that whenever you're dealing with obstetric codes, they'll tell you that's like chapter 15, but I don't ever think of it as what chapter number it is. I think of what the first character is. So I call them O codes. So O codes go first. Whenever you have anything happening to a female that's pregnant, those O codes trump anything else. So in other words, even if she falls and breaks her leg, there's an O code, that involves that. And so that's very important to understand. And then the O codes only are put in the mother's chart. They're not in the baby's chart. So once the baby's delivered, then the baby gets its own chart, and there'll be P codes. Think of P for pediatrician. That's how I think of it. But the O codes stay in the mother's chart, and then the baby gets a new chart, and there'll be P codes. Whenever you do anything with obstetrics, it's going to have a trimester. And I would say that you don't have to have the trimester memorized, but it's very important to be aware of it. Now, the reason you don't have to have it memorized is because it's everywhere. I mean, you can Google it in a second, or just look in your ICD manual, go to the O in your tabular, and it's right there at the guidelines in the beginning, and then it's usually repeated again and again throughout the tabular next to those O codes. One thing to remember is that the trimester is always indicated by the 7th character. That's going to tell you what trimester the mama is. And there's 3 trimesters. Whenever you're dealing with obstetrics, whether you're dealing with delivery or not, but especially with delivery, you're going to end up usually having more than just one code. Okay, so be aware of that, because there's just a lot of things that you have to tell in the story. And remember, it's statistics, right? Be aware of complications. If something can go wrong, it needs to be noted, okay? And if you're not familiar with obstetrics to be enough to be aware of everything that can go wrong, then it would be ideal for you to read the tabular a little bit. Just go through all those O codes page by page and kind of peruse them, like I say, for a little light reading, right? And just be aware of what some complications are when dealing with obstetrics. That'll make you faster, and you'll be able to get to a higher specificity. Well, I went ahead and put the trimesters on here. And again, this is in your manual. When you are dealing with the first trimester, it goes from 0 to 14 weeks. All right. Now, if it's 14 weeks and 1 day, then you're in the second trimester. Okay. So the second trimester is 14 weeks to 28 weeks. And then the third trimester is 28 weeks to delivery. Now, it's very important that we notate what trimester that the mother's in, because there are certain conditions that only happen in a specific trimester. So, for example, morning sickness that we all know about and hear about, it usually ends after the first trimester. Sometimes it'll go up to 16 weeks, but for the most part, in the first trimester, that's when you're going, if you're going to have complications, you usually see that as one of the complications, is the mother gets really low on fluids because she can't keep anything down, nausea. And as well, if a miscarriage is going to occur, a spontaneous abortion is a miscarriage, a lot of times it happens within the first trimester, okay? And so again, that's two things that are trimester driven. The second trimester, something that's trimester driven, is that that's when they check you for gestational diabetes. It shows up in the second trimester if you're going to have gestational diabetes. And there's no rhyme or reason as to why someone gets gestational diabetes. If she has it once, she may never get it again. She may get it every single time. You just don't know. Third trimester, of course, then you're pushing the finish line, you know, looking for delivery. Certain things that end up happening, more commonly, complications would be like preeclampsia, placenta previa, you know, the swelling, edema happens in the third trimester. And we'll talk about some other things too. So, you know, complications that can occur in each trimester for you to be aware of. And maybe a good idea to do a little studying on your own there. Now let's talk about inpatient real quick. Sometimes it gets confusing in sequencing. And it doesn't matter if you're a new coder or you're an established coder. Sometimes you just have to stop and think, wait, what's going to be listed first? The understanding with pregnancy is that if a patient is admitted, okay, what is the reason for the patient to be admitted? That's the first listed, or the principal diagnosis. But with pregnancy, things happen a little bit differently. Now, we just talked about the trimesters, and they're fluid. You know, they just go from one trimester into the next. So what happens if you have a patient that is in one trimester and is admitted, and then they are discharged in the next trimester? So what do? You know, for inpatient, that's different. Now, outpatient, just seeing the, you know, the OBGYN on the routine visits, that's not going to be a problem, right? Because it's an ongoing, you just list the complications. But if you're in-house, we need to know what was the reason the patient was admitted, and then was that condition there upon discharge? Now, when you are not an OB patient, a lot of times whatever you were admitted for was resolved by the time you were discharged. So if you were admitted for pneumonia, right, you're probably, you know, the pneumonia is, you no longer have pneumonia when you get discharged, or you're feeling much better, whatever. You know, a lot of things are resolved, like appendicitis. When you're discharged, you no longer have appendicitis because you usually don't have an appendix, right? Now, what do we do then if we have one trimester, and then in the second trimester, the patient is discharged? The key here is that if you have a complication that happens and the patient is in-house for two different trimesters, then you are going to assign the trimester date when the complication developed. So the example I created for you is that Judy is 12 weeks and 5 days, so she's in her first trimester when she's admitted for thrombophlebitis. She's DC'd to home 14 weeks and 2 days. Now, I just made this up on my head, so I don't know what a normal stay would be for thrombophlebitis and so on and so forth. I just was using it as an example, so don't overthink it, you know, the disease process here. Okay, so she is admitted in the first trimester and discharged in the second trimester. Now, normally with inpatient, we would think that if she was in the second trimester when she was discharged, we should use the second trimester as the code. But actually, it's not that way. It's complication developed, not the trimester of discharged. So when did the complication occur? So if she was in her first trimester, you would code for superficial thrombophlebitis in pregnancy first trimester, and it would be 022.21. And then the guidelines tell you, the tabular says with the code 022.21, it says, hey, by the way, we want to know more information. There's an I code that you need to code, and that was I80.01, phlebitis and thrombophlebitis of superficial vessel of right lower extremity. Now, again, don't overthink the disease process here. I was just wanting to show you an example of something that could be in one trimester that you'd be admitted for, and that you might be in house long enough that you were discharged in a different trimester, okay? But always don't code from the index, code from the tabular, because you wouldn't have known to code the I80.01 code. And again, don't worry about it being superficial thrombophlebitis. I just picked that code, right, for thrombophlebitis. I didn't want to make my example too long, too wordy, okay? So again, if the condition occurred in one trimester and you're discharged in another trimester, the principal diagnosis, the trimester will be listed as when it occurred. And that kind of goes against the way we would think, right? So make a note of that. Another scenario would be if you have a condition that develops while the patient is currently in admission or is a pre-existing condition, okay? The trimester character for the trimester at the time of the admission should be assigned again. Okay, so the example here, Rose, she's a type 1 diabetic. Now, she doesn't have gestational diabetes. She's a type 1 diabetic. And at 12 weeks and 5 days, which is first trimester, she's admitted for ketoacidosis. Now, ketoacidosis is something that occurs in type 1 diabetics. She's discharged to home at 14 weeks and 2 days. So what do? She is an 024.011 pre-existing type 1 diabetes mellitus in pregnancy, first trimester, and she's a E1010 type 1 diabetes mellitus with ketoacidosis without coma. Okay, so because the guidelines tell us, you know, we have a pre-existing condition of type 1 diabetes, and then we have a complication. And the guidelines tell you to code that. So if you go look at the diabetic code E10.10, it directs you to 024.0 if the patient is an obstetric patient, right? But the key here is first trimester, even though she's discharged in the second trimester, because it's a pre-existing condition. Okay, now the ketoacidosis is new, but it doesn't matter. It's the type 2 diabetes or the type 1 diabetes that we're talking about. So again, don't overthink the disease process. I'm just trying to give you an example of trimester here. And whether you know much about ketoacidosis, this was in Find a Code, so I went ahead and added it because you know me, I like to give you as much information as possible whenever I can, and I love Find a Code that does that. DKA, if you don't know what that is, that's diabetic ketoacidosis. And you should make a note of that. That very likely will come up on any coding exam that you're going to be doing ICD in. It's a common thing to be tested on. It only happens with type 1 diabetics, insulin dependent, and it's also considered a type of uncontrolled diabetes. What happens is you get too many ketones in your blood acid, and they body can't regulate itself. And so the signs and symptoms, I would kind of commit those to memory. Deep breathing, that fruity smelling breath, frequent urination, and in extreme cases, coma. So whenever you have a type 1 diabetic and all of a sudden they start acting really drunk, then and kind of for no reason, because diabetics, especially type 1 diabetics, shouldn't be drinking to begin with. But they start acting slurry and stumbly and not thinking real clearly. And then they have that fruity smell in their breath. Then that's a really dangerous thing that you want to check their blood sugar right away, and you also want to get them to the hospital. Just noted here also, when you have a pregnancy and the patient is a diabetic, you need to identify what type of diabetes they have. Now, if they have gestational diabetes, that's going to be an O code, right? Because gestational diabetes only occurs in pregnancy. So it's a different type of code. And if you look up any of the diabetic codes, it's going to tell you, hey, by the way, if this is gestational diabetes, you go pick up this O code. You don't use this other code. However, you can be diabetic and get pregnant. It's not gestational diabetes. So if you are a type 1 diabetic, you would be an E10. If you're a type 2 diabetic, you'd be an E11. There are other types of diabetes that a person can get besides gestational type 1 or type 2. It's one that's due to an underlying condition, that's an E08. Maybe there's a drug or chemical that has tipped the body into a diabetic state, that would be E09. And then other specified diabetes would be an E13. Remember, other signifies, hey, it's listed, there's just not a code for it, okay? So be aware of that. And notice that all of these are 0.1s because they have something to do with ketoacidosis, just so you know, okay? Very good, good stuff. I hope this isn't too small. I didn't want to make it too big, but I pulled this right off Find to Code. Now, how do we code for a patient that is being seen for their regular visits and they don't have any complications? Okay, it's going to be a Z34 code. This will be the first listed diagnosis. This will be outpatient. So again, you're dealing with a pregnancy, but why are they being seen? They're a Z34. They're being seen because they're having routine visits. And we know that it's standard that when you establish care for your OBGYN, you'll go like once a month in the first trimester. In the second trimester, you tend to go like twice a month. And then the last trimester, you end up going every week. And then the last week or so, you go every day. It's just standard protocol, right? So these are all Z34 codes. Now, let's break that down a little bit. What does Z34 stand for? Encounter for supervision of a normal pregnancy. So there's some excludes here to pay attention. If you have a complication in a pregnancy, then you're going to be looking at some O codes, O00 through O9A. If it's an encounter for a pregnancy test, that's different. That's a Z32.0 code. You may not have been aware of that code. So now you've got it in your memory bank. If you are being seen for encounter for supervision of a high-risk pregnancy, that's an O09 code. Thus, complication of pregnancy, O9A, and then encounter for supervision of high-risk pregnancy, O09. Don't get those confused. So again, those are other codes to be aware of. Now, let's say this is just a normal pregnancy. This is the first pregnancy. That is the Z34.0. And then there's, it's going to divide up. That next character will be what trimester they are, the first trimester, second and third trimester. And then there are a couple other codes, though, that are kind of confusing. So look at Z34.8, encounter for supervision of other normal pregnancy. And then you have Z34.9, encounter for supervision of normal pregnancy unspecified. Now, what does that mean? What does the other mean and the unspecified on these Z34 codes mean? What separates point 0 from point 8 and point 9? First pregnancy. They're all normal pregnancies, right? In other words, we don't have any complications involved. So again, Z3 4.0 is supervision of normal pregnancy. Point 8, other normal pregnancy. And then 9 is unspecified. Well, what does other mean, right? And what does unspecified mean? Just standard rule, okay? Normal means it's not the first pregnancy. So there's not an additional code for second, third, fourth, fifth, sixth pregnancy. Can you imagine how many codes that they'd have to have for all of that? And there's no rhyme or reason or commonality, 2.1 or 2, pregnancies. And again, so it would be anybody that's had more than one pregnancy would be a Z3 4.8. Okay, it's not their first pregnancy. It's an additional, a second or 15th pregnancy. Doesn't matter. Now, Z3 4.9 though is unspecified. Why would you use an unspecified? Well, we're not sure if it's the first or a second or a third pregnancy, because unspecified means it's not documented. We don't know. Normal, other, means, it's not their first, but there's no other code for a second pregnancy or a third. And then Z3 4.0 is only used for a first pregnancy. Why do you think that they divide those up? Why do you think that first pregnancies get their own codes? Because first pregnancy is always kind of a learning curve, right? How's the body going to react to pregnancy? Do you have any family history of complications with pregnancies, right? Now, I have 2 daughters, and if you look at complications that I've had with pregnancies, then again, they always put that in. Well, my one daughter's married and has children, but my other daughter isn't married and has no children. So it's noted in her chart. She always lets her midwife know anything that had happened to me. And so far, she's not had any of the complications and problems that I had. But a first pregnancy is kind of a clean slate, right? A little more, of a learning curve there to see if, and it's going to take more education for that patient because it's the first pregnancy. They're going to have more questions. I always like that commercial or the little story. You may have seen memes or something where it says, the first pregnancy, and they've got this big giant bottle of sanitizer and stuff, right? And you get resumes before you get a babysitter and stuff like that, and you call like 3 times the babysitter to make sure everything's okay. And then by the second and third child, you're just dropping them off with anybody, and you don't call, and you're enjoying your time away. I found that to be very true with all of my children. So again, more time is probably going to be involving in an encounter for a first pregnancy than it would be for even a normal subsequent pregnancy. Right? So now those codes, you understand those codes. If you have a high-risk pregnancy, then again, we mentioned that was going to be 009 codes. Now look at your options. I wanted to take some time to kind of flesh these out because one of these, if I see it here, due to age, and I keep forgetting to go look up the age that makes you an elderly. It's listed like elderly mother, and it's like 28. I got to do that because I was talking about it the other day. So let's look at our first code range: supervision of pregnancy with history of infertility. All right, very important. Not only for infertility doesn't mean that they've had miscarriages. Infertility means that they've had difficulty getting pregnant. okay? And therefore, it's going to be supervised a little bit differently, and also probably a lot more questions, you know, counseling time involved. Pregnancy with a history of ectopic pregnancy. Why do you think that's important? Think to yourself. The reason people have ectopic pregnancies, which a lot of times end up happening in the fallopian tubes, is due to things like scar tissue, endometriosis, stuff like that. So if you have a patient that's had one ectopic pregnancy, they've definitely, that was a fallopian pregnancy, they've probably lost one fallopian tube, okay, because they'll remove that when they go in. However, so that makes it a little bit different, but that means that whatever condition caused the ectopic pregnancy is still there, most likely, and could be complicating the whole supervision and delivery. The next one, I ended up making this a little bit smaller. Sorry about that, because I wanted to fit that all on there, not having on another line. Supervision of pregnancy with other poor reproductive or obstetric history. So that's not a catch-all. Poor reproductive or obstetric history means that we don't know much about what was has gone on. Let's see, with insufficient a neonatal care, that means that the patient had no prenatal care whatsoever, or there wasn't enough in the standard of care. So that means you haven't followed that pregnancy, and it's kind of like an open book as to what could happen. Definitely more counseling and medical decision making involved there. Pregnancy with grand multiparity, meaning we've had more babies. Prima gravida and gravata, multigravata of the elderly, meaning the patient's older, meaning it could be just older than 28. Young, the child is, or the mother is very young. High risk pregnancy due to social problems. This could be social problems with maybe abuse. Other high risk pregnancy, well, there's that other, that means there's something else that makes this a high risk pregnancy, but it is, there's not a code for it, unspecified. It's a high risk pregnancy, but it wasn't listed. And history of molar pregnancy, which again is a very specific type of pregnancy. So I was an 009.5 multiple times with mine. Because of my last child, I was 38, and I had actually, he was my last child, and I didn't get pregnant after him, but I had been pregnant 19 times, so I had 19 miscarriages, so I was an 009.5. Now, that's why with my daughter, who's now pregnant with her number 5, hasn't had any of those troubles. So again, it's noteworthy though, but whatever was wrong with me wasn't her, you know, passed down to her. Everything's tracked. So what happens when we have a patient that is admitted, okay, so this would be inpatient, for a complication or a problem, but there's no delivery. So there's a lot of things that can happen here. Note that you can even have more than one complication. So I picked this scenario. Anne is admitted for hypertension, gestational diabetes, hyperemesis, and fever at 15 weeks and discharged home after hydration. So the first thing we know is that she's in her second trimester, right? Because she's at 15 weeks. And I didn't put how many days that was, because usually it would be just like a one-day thing, hydrating. Why is she sick? Well, we don't really know, but obviously she has a fever. Okay, so maybe she is, and you're out of, you're kind of out of the time for morning sickness, because that ends between 14 and 16 weeks. You know, usually it's done by then. But hyperemesis, you throw up a lot, right? But we have several things complicating this pregnancy. The patient has some hypertension going on, and that could be just because she doesn't feel good and she's dehydrated. Gestational diabetes. So if she can't eat and she doesn't feel like getting up and moving around, her blood sugars are going to go up. Hyperemesis, can't keep anything down, dehydrated, and she's running a fever. So what do we list as the complication? Every one of these are complications, okay? And she doesn't deliver. She's only at 15 weeks. So she's admitted with complications and treated for those complications and released home. So no delivery. The principal complication of the pregnancy that necessitated the encounter. So why was she admitted? Well, she was admitted for a combination of all of those, right? And you'll ask the provider, you know, why was she admitted? Query the provider. If he says, well, the gestational diabetes. So you list that first, and then it doesn't matter. But if it's all of them, then it doesn't matter. Any of those could be sequenced first, okay? And yeah, it looks like the question said, that came up in the chat, you can have a pregnancy but not a birth. Yeah, because you're pregnant for 40 weeks, and you could be admitted for all kinds of reasons before the 40 weeks is up and not deliver, right? That would explain that. I think you can only code BMI during pregnancy if the BMI is complicating the pregnancy. That is an excellent point, Whitney. That is true. That's right. So, of course, the mother's going to gain weight, right? And your BMI is going to go up because your weight's going to go up. They say they don't want you to ever gain more than 40 pounds. So 30, 35 pounds to 40 pounds is ideal. And most of that is fluid. Because if you think about the baby, you know, most people don't have 10-pound babies. Their average is between 7 and 8 pounds. And you gained 30 pounds, well, the rest of it is fluid, pretty much. So your BMI is going to go up. Now, if you were like me, though, my last 2 pregnancies, I had morbid obesity. So my BMI did complicate my pregnancy, and it was listed that way, okay? So I had morbid obesity as a complication that made me high risk, and then my BMI was listed. But let's say you're right on the cusp there, and you gain 60 pounds, but and your BMI goes up, but the doctor does not list the obesity or anything like that. You can't. You know, it can only be listed if it's complication. Really good point. I should add that into a test question, shouldn't I? That'd be good. So I like to ask people, how many types of birth are there? How many type of deliveries are there? And most everybody will say vaginal and cesarean, but actually there's 3. So you have vaginal, you have cesarean, and you have vaginal after cesarean, which is called a VBAC. A VBAG. And they're coded as such. So if you have a vaginal delivery, say your first child is born vaginally, your second child is born via C-section, and then your third child is born vaginally. That third child was delivered vaginally after cesarean, which would be a VBAG. Okay, and you can do that in any rhyme or reason. Okay, so if the first child was a cesarean and you had 3 children, the next 2 are VBACs. So anytime a cesarean occurs, if you try to deliver vaginally after that, you're a VBAC. Now, let's say you tried to deliver the third child. Let's go to the first scenario. Number 1 was vaginally, number 2 was a C-section. Third, you try to deliver vaginally and it doesn't work, and you end up having a C-section. So then you're a a vaginal, you're not a vaginal after cesarean, but there's a code stating that you attempted a vaginal and ended up having a cesarean, okay, post-cesarean in the past. Make sure you note if there's a delivery, every time that on the mother's chart, delivery, the outcome of the delivery has to be coded. So every time the mother delivers, the outcome of delivery is coded, whether it's a cesarean, C-section, or a C-section, vaginal delivery, or a VBAC. You know, it's always going to be listed on there. And also, you'll have one like single life born. Okay, so if you have twins, you'll have, and they're both live born, then you'll have, you know, twin live borns. So you have vaginal twin live born, right? If one is deceased and one is alive, then there's a code for that. You know, one live born, one stillborn. And note the definition of stillborn. You just take your time to go and look at that, because a baby that is born after or in the third trimester is no longer considered a miscarriage. That's a stillborn baby. Can we talk a little bit about sepsis and obstetrics? Yeah, we can. Let's get through these and let's do that. I didn't add this on here because it's really a complex, sepsis in itself is very complex, and we might, I'll highlight it, but that may be a good study on its own. In fact, it would probably make an excellent public Q&A, you know, the second to the last Thursday of the month. Probably be a really good time to talk about that and do a slide on that alone. Anything that can happen to a mother, or anything that can happen to a person, can happen to a pregnant woman. You know, so sepsis, absolutely. Just keep in mind that if it's sepsis before delivery or sepsis after delivery, because if it's sepsis before, it's complicating a pregnancy and making you a high-risk pregnancy, right? And most likely, if the baby is, if you're in your third trimester, they'll go ahead and deliver. They'll C-section you, because you could pass the sepsis on to the baby. But if you're you know, you're in your second trimester, they can't really do that. The baby, you know, is less likely to survive. But if it's really bad, but, you know, sepsis, again, is an infection that goes throughout the whole body. Severe sepsis, you start having organ failure. And you don't want an infection in the body, systemic, anyway, when you're pregnant, let alone have an organ failure. And but sepsis usually is connotated with pregnancy after delivery. So you've had an abortion, and there were complications, and therefore or infection, because you're opening up the body and entering the body obtrusively, and to an area that's supposed to be sealed and sterile, you know, environment. You're introducing, and not all of those procedures are performed in places that are, quite honestly, clean, because there's no protocol for them, hardly. Anyway, we won't talk about that. But it's very common. And then also, if you had retained products of conception, right, you can get an infection and then go septic. So with sepsis, is it sepsis during pregnancy or is it sepsis after delivery? Going to make a difference. Another scenario, when you deliver and the condition that prompted the admission would always be the principal diagnosis. That's standard rule, right? But let's say we actually have a delivery. Let's say that in this instance, the conditions established after the delivery and is responsible for the patient's admission. Okay, so the example I thought up was Lily's admitted for a C-section due to blood pressure of 220/108, swelling and headache and protein in her urine. Well, that's preeclampsia. So what is the primary diagnosis? It's 0.14.14. She's preeclamptic, and you have to deliver or you have a stroke. And I know people that I know at least one person, I know two, but I knew one person much better than the other. And that's life-threatening for both the mother and the child. But what happens if you have a reason for admission was unrelated to the condition resulting in the cesarean delivery? Okay, then the condition related to the reason for the encounter should be selected as the principal diagnosis. So in the first scenario, the patient is admitted, has a C-section. Why did she have a C-section? Because she was an 014.14, and that's the principal diagnosis. Whereas if you have Abby is admitted from a moving vehicle accident with a fractured femur at 38 weeks and has a C-section. So why was she admitted? A moving vehicle accident and a fractured femur. And so and she was already at 38 weeks. Yeah, they went ahead and delivered, because she's probably going to have surgery for the fractured femur, right? So deliver the baby, then go do the procedure for the femur or the treatment for the femur. And a moving vehicle accident, there could be other problems involved, right? Whenever you have a mother during pregnancy has any type of a moving vehicle accident and everything, that's serious. Definitely would want to get checked out. One of my really close friends from high school, her daughter had she was run off the road accidentally and had a motor vehicle accident. And I'm trying to remember, I think she was like 37 weeks or something. She might have been at 38 weeks. And she went in and she got checked out, and they were going to send her home. And her mother said no. And they went ahead and induced her, and the baby died, because there's a type of like a toxic shock that can happen to the body and to the baby, and the baby succumbed from that. So again, you don't want something like that happening. The body goes into shock and overwhelms the baby itself. So on the first reason, you have a C-section. Why? Because of preeclampsia, severe preeclampsia. In the second, I just didn't pull the codes, but you have a motor vehicle accident, which would be a Z code, but the fractured femur would be the reason for that would tell the story. Now we're going to look at a little bit of anatomy. One of the complications that's very common is breech in children, the positioning. So whenever you're reading the report for the delivery, whether it be a C-section or a vaginal delivery, the positioning of the baby is going to be stated. And, if the more of these procedure notes for delivery that you read, the better you get at it. But the positioning of the baby is very, very important. It can be a complication of the delivery. So I thought, let's just go over those. We'll wrap up with positioning of the baby in this. A frank breech, and it's called frank because the person that discovered it was, I think their last name was Frank. A frank breech is going to be when the knees are extended. Okay, so sometimes you see this with their little legs up like this and their little bums, so they're going to come out bottom first. And what's funny though, if you have a breech baby like that, after they're born, they've laid in that position for so long with their little legs. So say this is their body and this is their little legs. Their little legs stay like that, and you'll lay them back down and the little legs will come back up. And they'll lay them back down, the little legs come back up. It's kind of funny because the body had been in that little bent position for so long that the legs want to stay up. So again, that's when both hips are flexed and both knees are extended. A complete breech position, you've got, bum first, but the knees are flexed. Okay, so the knees aren't extended, they're flexed. So the little baby's sitting kind of cross-legged somewhat, but still coming out bum first. Okay, incomplete breech presentation, that's when you've got both hips are not completely flexed. You've got something else, you know, the legs are going to come out first. And in some ways, this can be good, and in some ways, this can be bad. There's protocols to deal with every one of them, but what really becomes a problem is where's the baby's umbilical cord, right? You don't want it pushing down, and when the baby's, you know, the cord's coming down with the leg, that can be a problem. So the three most common types of breech are frank, complete, and incomplete. And those are all going to complicate a delivery. So make note of those. You don't have to have them memorized, but you'll see them in the documentation. Now let's talk about head position. A normal head is going to be when the baby starts to come down into the vaginal canal, the baby comes down face pointing backwards. Okay, so when the baby comes out, the back of the head is here, and the face is down this way, and then the baby will turn and rotate. Breech again is going to be bum first. Little bottom's going to come out first. Then you have a face presentation. So instead of the baby's cranium coming out, which has those fontanelles and stuff, so the head can smash and move a little bit, the baby comes down face first. Well, you can see how this is going to mess with the neck, right? This isn't a good position to come down, because they're going to come in with the face coming out first, and the head can't squeeze properly. Right? The face doesn't squeeze like the little cranium. And then, of course, a shoulder presentation. And a lot of times, shoulder presentation, if they know it's going to be like that, they just do a C-section. But they go in and they literally stick their hands up in there and turn the baby. But those are the main types of abnormal delivery. So you've got, even in those three categories, breech, face, and shoulder, there's subcategories. So like breech, we know 3 breech deliveries. You have frank, complete, and incomplete. And then face positions, there's all different face positions, is where the baby came in and whether which way the baby's positioned, and shoulder positions as well. You can make that even more distinct. What happens when you have twins? Well, most of the time, you know, it would be nice if the babies are both facing down. Well, that isn't necessarily always going to happen. And remember that a lot of times, well, it depends. Are the twins in one sac or 2? So are they identical twins, or are they fraternal twins? So if they're fraternal twins, they each have their own sac. And whereas, you know, so they're in there together, they're identical. Whereas if they're not, then you're going to have a more. Now, I wasn't for sure, but I think that is the percentage of the most common ways that they're found. So if it's a vertex where they're both head down, 40 to 50% of baby twins are that way. Vertex breech, meaning vertex head down and the other baby's breech, 30 to 40%, and then breech and transverse. So the baby's going to come down breech, and another baby is on top sideways. That could come down like a shoulder, or may turn and come out. But that is like 20%. But I think that's what those were. And I also notated where I got these pictures, by the way, the graphics, in the resources, so that you can go back and look at those a little more in depth. Now that we've talked about abnormal, if you're going to read the reports and stuff about delivery, it would be a good idea to understand what happens with the rotation and the positioning of the baby on a normal delivery, because they're going to read off what happens normally. So I'm going to assume that you already know the anatomy, and for the most part, you're past that part. So the first thing, the first position that the baby gets in, where it's starting, delivery has started and the cervix is opening and flattening out, is going to be the flexion. Okay, so the baby is starting to position and move its way down into the birth canal. Then there's an internal rotation of the head. So notice that you've got the baby right, kind of sideways, and then the baby starts, the head and the baby starts to turn, because it's going to come out with this face looking down. That's ideal. That's what you want. So the baby's going to start to turn as the cervix and everything's dilating and getting ready. And then you're going to have the extension. So when you have internal rotation of the head, that's where you start hearing them talking about presentation. They can see the baby. This is when they get to that point, that's when they start pushing. And that stage can take a very long time, or it can not take very long, just depends. But notice that if you look at the anatomy, when you get to that flexion portion, you start getting a lot of pressure on the rectum, right? And then when that baby starts to present, then you really got a lot of pressure and you want to push. So this extension is that next stage. And notice that the baby's head is with the face down, but then there's an external rotation where the baby kind of pops out and then the face turns to the side. And then the baby just kind of slides right out after that, because the largest part of the baby is the head. And that's why you want it coming out first. But delivery is not done. Delivery doesn't actually finish until after the placenta comes out. And it can take 5 to 15 minutes for the placenta to come out. You don't want it to take longer than that, okay? So usually after the baby comes out, the uterus will have another contraction, and then the placenta will detach and come out after that and separate from the uterine wall. And then the uterus will start shrinking back to its normal stage. And they'll go in and they'll massage the uterus. That can take, a few hours for the uterus to start shrinking back down. But the placenta, if it doesn't come out on its own within that short amount of time, then that's a complication. And you're going to see them notate that in the documentation and do a procedure. Also, if it detaches and abruptly, like it's pulled, like they'll hold a little bit of tension sometimes, but they will never pull it, because then you could hemorrhage. And that would be a complication, is hemorrhage, because there's normal hemorrhage after delivery, but there would be an abnormal hemorrhage due to the placenta being torn away. It should release, separate, but not be torn away, and can cause problems. I'm trying to think of any other complications that would occur with that. Let's see. Again, you've got your positions where the baby is prior to delivery. If they know the baby is breech in the third trimester, the mother can do things to promote the baby flipping. And one of the things they'll have you do is kind of like get a board, so like an ironing board or some type of a board, and you put it up against the couch and lay with your head down and your hips up, and that baby will kind of flip on its own. My daughter had to do that one time, so that's kind of common. But they can go in and twist the baby, a manual movement of the baby, and again, it depends how many weeks you are, but they aren't going to do that until you get into the third trimester. Other complications would be placenta previa. So let's say everything looks good. You go into that flexion state, and then all of a sudden you get bright red blood, and you see the placenta start to come out instead of the baby's head. that's bad. Okay, and that can result in hemorrhaging, and a lot of times that'll result in you having a C-section. So it's called placenta previa. There's another procedure or complication that can happen where the uterus starts to invert and come out. And a lot of times this happens after the baby's born, and the baby comes out, the placenta comes out, and then the uterus comes out. And of course the uterus is attached. So you have to have a procedure to put the uterus back in. And that also means that there's been times where the uterus tries to come out during pregnancy at other stages. So again, these are all types of complications that are coded. Every time you go to code any complication or anything during pregnancy, of course, you're going to list the complication and the gestational weeks that the baby and the mother's in. I'm glad you're enjoying this, Betsy. And that is about it. I think that was, yep, that was the last one. Any last minute, again, with sepsis, let's talk about that in another lecture. But for the most part, just to reiterate, you need to ask yourself, you know, is this sepsis during pregnancy or is this sepsis after delivery? And most of the time you'll find that it's sepsis after delivery, but you never know. Think about if you're pregnant and you have appendicitis, or you and your appendix ruptures, or you get maybe a spider bite or something, and then it gets septic. I mean, there's all kinds of things that can happen, right? Right. Students, don't forget that if you are a general student and you're interested in becoming a prime student, go to the cco.us /club. If you're joining us on Facebook and YouTube and you want to know more about our the perks to being a student, we have more than one way you can be a student. You can be, I guess, a standard student, basic student, or you can join our Prime program that allows you to take all of our courses, one right after the other, for a one-time nominal fee of under $500, and then you pay a fee every month, which is like $40 some. I can't remember exactly how much it is. Just go to the cco.us /club, and then you get access to that course, the exam, and the blitz, if there's a blitz associated with it. And we continue to add courses as we go along. We have lots. That's it, guys. I'll see you next time. The resources are all listed there. And of course, if you are a student or a club member, you have access to print these off. If you're just joining us on Facebook or YouTube, you don't get that privilege, and this will be taken down. You don't get to watch this again later. Whereas our students and prime students, they get to watch this as many times as they want and print off the slide deck. All right. Bye, guys.